Good afternoon. Welcome to the 5th ASPA 3 webinar series. Navigating neuroanesthesia in children involves addressing age-related differences in drug responses and the intricacies of neurophysiology in developing brains. A pediatric anesthetist who don't regularly manage neurosurgical cases might face challenges due to the complexity and specialized nature of the procedure, demanding meticulous planning, distinct skill sets, and experience. I am Teddy from KK Women's and Children's Hospital and Philippine Children's Medical Center. Join me as your voyage captain this afternoon as we dive into the abyss of challenges that may arise in procedures such as awake craniotomy, epilepsy, and aneurysm surgeries. Before we formally begin, let me share with you some housekeeping rules. You can send your questions or comments via Q&A section. The chat and raise hand functions are both disabled. Our moderators will highlight your questions to the appropriate speaker during the panel discussion. Some questions will be answered by text with the appropriate speaker in the Q&A section. We will be sharing few poll questions later. You'll be prompted to answer the polling questions when a poll is launched. You'll be given 30 seconds to respond and submit your answer. We will share the results soon after we end the poll, and you may close the poll after the result is shared. The certificate of attendance will be automatically generated and forwarded to those who submitted the post-webinar survey, and the post-webinar survey will be emailed tomorrow at 5 p.m. Please ensure that you keyed in your full name and email correctly. The recorded session of this webinar will be uploaded in our YouTube channel, Facebook page, and our website. Please visit, like, and follow us. Joining me as my co-captain for this afternoon's voyage is Dr. Marichu Diaz-Batad. She is our senior consultant in the Philippine Children's Medical Center and the head of the Pediatric Anesthesia Council of the Philippine Board of Anesthesiology. She's also our former president of the Philippine Society for Pediatric Anesthesia. Dr. Marichu, handing over the screen to you.
Okay, thank you, Teddy, for the warm introduction. Okay, at this point, it is my great pleasure to introduce our first speaker, Dr. Derek Chan. Dr. Derek Chan is a senior consultant and head of pediatric neurology at the KK Women's and Children's Hospital in Singapore. He's also the program director of the Innovator Development Program and the vice chair in research of the Pediatric Academic Clinical Program. He is also the research director at the KK Women's and Children's Hospital in Singapore. His interest includes epilepsy, EEG, and pediatric neurology. So may we call on Dr. Derek Chan to talk on the considerations for epilepsy surgery.
My name is Derek Chan. I'm a pediatric epileptologist, and it's a pleasure to be speaking at this ASPA webinar. I'm going to be talking about considerations for epilepsy surgery in children. Begin with a little introduction about epilepsy and drug-resistant epilepsy, and walk us through the workflow for the investigation and management of epilepsy, as well as the considerations of types of epilepsy surgery, and then ECOG. Epilepsy is important because it's one of the commonest neurological conditions in children and adults. In fact, seizures occur in 10% of all population throughout their lifetime. And the incidence of epilepsy ranges from 45 to 300 per 100,000 person years. 1/3 of these patients are refractory. And what this means is basically that epilepsy is common. So many of these children are likely to undergo anesthesia at some point in their life. And anesthesia is key, particularly in younger children, in the epilepsy workup and the treatment itself, particularly surgery. This is the classification by the International League Against Epilepsy for the 2017 seizure types. And this helps us to actually characterize the type of seizures our patients have, and if they are diagnosed to have epilepsy, it helps us to determine what kind of epilepsy they have. So the key steps in epilepsy evaluation is making sure, first of all, the patient has epilepsy, such as making sure that they don't have some other condition or some acute symptomatic cause, to make sure that if we do have epilepsy, that we try to identify the correct syndrome, because this helps us to get the correct prognostication, investigation, and treatment. And then if we're giving the correct treatment, to make sure we're using the right anti-seizure medication. And then, of course, when to change course. When do we decide when anti-seizure medications are not enough to control the seizures and we need to look at other causes? So really important when we think about anti-seizure medicines that we get the right medicine and administer it in the right fashion and give it for the right epilepsy. As an example, carbamazepine, if given in absence epilepsy or myoclonic epilepsy, will give rise to much worse seizures and lead to a clinical picture that's described as pseudo-refractory epilepsy, where they seem to be refractory, but it's due to incorrect use of medication. Assuming we do get the right medication, we initiate by gradually titrating up to minimize side effects, and also so that we can identify the lowest dose that controls the seizures. And if we discontinue, then again, we need to gradually titrate down so as not to endanger the patient. When patients are put nil by mouth, it's very important to give them their doses early if they're going to be put nil by mouth, and during that period to give them the intravenous form if available, and if no intravenous form is available, to then make sure that we continue to administer the anti-seizure medicines through the NG tube. Very importantly, we should never ever suddenly discontinue or skip doses without a very good reason, because the risk of exacerbating seizures is very high. The few circumstances which might justify discontinuation would be a severe allergy, such as Stevens-Johnson syndrome, or perhaps a severe gut problem, such as gastrointestinal perforation. But in those cases, we would usually administer other medications to cover them against the risk of seizures worsening. So if we look at the therapeutic workflow for epilepsy, once we diagnose epilepsy, we'll treat them with medication, and if they don't seem to be responding to medication, we'll start to investigate to see whether they are good candidates for epilepsy surgery. And then based on this evaluation, we'll decide whether to push forward to resective epilepsy surgery, or whether if they're not a good resective surgical candidate, they should have other treatments which are not designed to control the seizures as much, but rather to mitigate the severity of the condition. And this includes vagus nerve stimulators, corpus callosotomy, or the ketogenic diet. So drug-resistant epilepsy, or also known as refractory epilepsy, occurs in about 30% of patients, and once they have had 2 adequate dose trials of good medications appropriate for the type of epilepsy and their seizures are not controlled, then they're considered to have drug-resistant epilepsy. The rationale for considering epilepsy surgery is because the impact of seizures on the developing brain is high in terms of effects on development, cognition, and behavior, and these do not reverse if the seizures are controlled later. The epilepsy in children is much more diverse than in adults, in multiple lobes, and hence gives us a more complex picture and evaluation. But it is also helped by the fact that they have neuroplasticity, and so if we're able to stop their seizures, the potential to repair and remodel is higher in childhood. For some patients who don't have refractory epilepsy but have a clearly defined lesion which is amenable to surgery, we will consider epilepsy surgery, because then there's a prospect of cure and the patient may actually come off medication completely. So the types of epilepsy surgery can be divided into resective, where the goal is significant reduction or cure, And the percentage success can be very high, particularly 70–80% in lesions in the temporal lobe or very clearly defined lesions which are visible anatomically. The percentage successes can be lower in other lobes, particularly like the frontal lobe, can be down to 50–60%. The goal ultimately with resective epilepsy surgery, the lowest minimum objective is to reduce seizures by 50%, though of course we hope that they will have a more than 90% reduction or no seizures at all. Palliative epilepsy surgery, this is intended to reduce the seizure burden and therefore the comorbidities. And examples of this includes corpus callosotomy or vagus nerve stimulator implantation. So when we look at the evaluation for epilepsy, or for drug-resistant epilepsy, we'll look at the seizure semiology to give us some clue that they have a consistent focal epilepsy that localizes or lateralizes to one side. We'll do EEG monitoring to try to localize where those seizures are coming from. And in addition, we will try to do structural neuroimaging and functional neuroimaging so that we can correlate the EEG findings and the clinical findings with imaging. And if we have enough information based on that, then we will proceed with surgery. There are times when the information from those investigations is insufficient, and then we have to proceed to intra or extraoperative monitoring. So this is an example of an EEG of a patient who is having a focal seizure. And if you look carefully in the second row, which is the blue colored rows of EEG and T4 and T6, you can see the beginning of a seizure in the right posterior temporal lobe, and then as the seizure progresses, becomes more prominent and spreads to other parts of the brain. If we look at this patient scan, we can see that actually there is a lesion in the posterior quadrant, and that is sufficient. There's a structural lesion, which in this case looks like a DNET, and they have an EEG correlate, and it's enough for us to proceed with surgery in this patient. Other patients in which it is more complex and less clear what the target and the epilepsy surgical plan should be. And so this patient has actually hemimegalocephaly on the left side, but also an abnormal and hypoplastic or atrophic right hemisphere. And here you can see the coronal lesion, hemimegalocephaly on the left side with ventricular enlargement. There's gray matter heterotopias, matter sitting all over the white matter regions, and it is grossly abnormal. It's polymicrogyria, but the right hemisphere is not entirely normal itself and looks somewhat atrophic. So in this patient, the question is, do you perform a hemispherectomy on the hemimegalocephaly, and how sure are we that the patient doesn't have seizures coming from the quotation marks good right hemisphere? There's also abnormal anatomy, because there's distorted anatomy, the difficulty of looking into seeing where the tracts and the normal lobes are. Tractography, tractography to help us to identify where the functional pathways are for that brain. And we use PET scan in this particular patient because, as we said, we are not entirely certain where this abnormality is with regards to seizures. And so with regards to treating them or doing the scan, we will usually admit them, and we aim for an interictal PET so that we try not to have seizures, so that we can identify areas of hypometabolism. And to that end, we admit the patient the day before and preferably load them with an anti-seizure medication to suppress the seizures, so we have the best possible scan. So this is that patient with hemimegalocephaly, and here you can see that the bright areas, particularly brighter green and red, are the areas of increased metabolism, and the darker blue or cooler areas are those which reduce metabolism. And in this patient, we're able to actually see that the left hemisphere is metabolically less active, and we don't see that corresponding on the right hemisphere. So together with the anatomical abnormality on this MRI scan, as well as the EEG patterns that we're seeing, we are able to, with a degree of confidence, say that the seizures are arising in the left hemisphere and proceed with a anatomical hemispherectomy on the left side. In some situations, particularly older children who are able to cooperate, we want to localize the function, and so particularly for language, functional MRI can be of value to tell us whether or not the patient's language centers have lateralized to the lesion side, or whether they have compensated by developing language in other areas, which makes epilepsy surgery safer. Epilepsy surgery planning can be divided into lesional resections, where it's a very specific small lesion. You can also remove larger areas such as lobectomies or hemispherectomies. And another component of epilepsy surgery is when we have to perform intraoperative or extraoperative neurophysiological monitoring. If we look at this neurophysiological monitoring, we call it electrocorticography. We use it intraoperatively during the epilepsy surgery to delineate the epileptic lesion, also to perform functional mapping so that we can refine the epilepsy surgery resection plan intraoperatively, right at the operating theater. So this is a young lady who had frontal lobe epilepsy. I'll give you a second to just see if you can identify her lesion. And it's actually here, so she actually has left frontal lobe epilepsy. You can see this blurring of the gray-white matter, and the cortical ribbon is less clear. And here it is again in the coronal scan, and this time it's on T2, and we can see this bright area in the subcortical white matter, which also corresponds to that dysplasia. So something we have to be careful with, because this young lady is a right-hander, and therefore her expressive language is in the left hemisphere. And so she underwent left frontal lobe epilepsy surgery with electrocorticography, and here you can see the electrodes placed on the brain surface. We initially placed them over the brain before resection to get the baseline patterns of what the EEG electrocorticography looks like, and then following resection, we'll repeat the electrocorticography to see if we have eliminated the epileptic spiking areas and to see what the residual area looks like. This is another patient, different patient, who had a left anterior temporal lesion and was also right-handed, and therefore the surgery was in the dominant left temporal lobe. And here we implanted or placed a grid on the brain surface so that we could perform electrocorticography and mapping, and therefore we can actually see that we are able to delineate the extent of the epileptic discharges for the lesion, and then to actually resect only the area which we feel is essential for seizure control. Briefly, just some intraoperative anesthetic considerations for ECOG. So like we said, there are two things we're doing. One is looking at the spike pattern, the interictal spike pattern, or if they have seizures, the ictal pattern, although that is unusual under anesthesia. And as well as, secondly, the intraoperative mapping. This is typically limited to motor areas. So to optimize intraoperative mapping, we usually will recommend 20 minutes prior to stimulation to adjust. We usually use isoflurane to keep the MAC at around 1.0. You can use remifentanil, but for patients, because we're going to do mapping, we do not want to have paralysis in the period just before we start mapping, although analgesia is entirely appropriate. Now, extraoperative monitoring was used less, and this is something where we will implant invasive EEG monitoring electrodes on the brain surface, and then remove the patient to the ward, typically the ICU, record their seizures, locate where those are, and then also perform some functional mapping, and then bring them back to operating theater and do surgery tailored to remove the affected area but preserve functional eloquent areas. And this occurs in 4 stages. There's implantation, recording seizures, mapping, and then explantation and resection. Following implantation, we do want to see typical seizures, but if we see new or atypical seizures, we become quite suspicious. And that's because the complications of motor are quite significant. This includes hemorrhage, stroke, infection, and status epilepticus. And some measures or considerations with regards to medications and fluids is we will not use NSAIDs because that would provoke hemorrhage. We tend to use saline so as to minimize the risk of edema or stroke. We tend to use prophylactic antibiotics, but we do not use steroids because steroids actually suppress seizures. So not something we do very often, but this is an example of a child who had quite severe right frontal lobe epilepsy. Here we actually performed extraoperative monitoring. She is, if to orientate you with the scan, or the picture, basically she is lying with her head facing us or down the bottom of the screen, with her head turned to the left. And so on the bottom left of the picture is her right frontal lobe. In the top of the picture is actually her right temporal lobe. And in the right-hand side of the picture is actually her right occipital and parietal lobe. And so here you can see that we performed actually mapping in the ICU with her awake, and we're able to delineate her motor strip in the areas marked with yellow. And then we're also able to see from her seizures that she had quite extensive areas of seizures coming from the right frontal lobe, unfortunately encroaching into her motor strip, but we were able to perform a tailored resection and attempted to preserve her motor strip. So another example is a patient with MRI brain which showed right frontal dysplasia, treated medically for many years, and then we move forward with epilepsy surgery evaluation after almost a decade, and also put him through fMRI, essentially to try to identify his speech areas, because he is also a right-hander and therefore left hemisphere dominant, and his expressive language will be coming from his left frontal lobe. Eventually he did have to go for epilepsy surgery because neuropsychological evaluation showed that his cognition was plateauing because of his seizures. Here you have his PET scan, and actually here you can see this area of hypometabolism in the left front. And if we look in his MRI scan, actually you can see the abdomen, and it's that blurring of the white mat of the gray-white border, thickening of the cortical ribbon. And this patient actually had an awake craniotomy and actually underwent epilepsy surgery to resect the left frontal lobe. Unusual, we don't tend to use this a lot in children, but he was quite an old teen by the time we did. These are just pictures from his surgery. Some other considerations for anesthesia in epilepsy surgery. Generally, we will load with additional anti-seizure medication after surgery because we're causing an iatrogenic brain injury, if you like, and so frequently we'll load them during epilepsy surgery, and our anesthesia colleagues are great at doing this for us. And traditionally we use phenobarbital or phenytoin, but it depends on the medication choice based on what their maintenance anti-seizure medicines are. We'll keep this for about 3 months and then wean it off after. Other considerations include minimum age and blood loss. We generally won't do surgery below 3 months, and we will attempt to temporize medically until the surgical risk falls. Although occasionally in severe epilepsy cases, which is life-threatening, we have performed it below the age of 3 months. The ketogenic diet is a low-carb diet, and if they are on this as part of their treatment prior to epilepsy surgery, very important to avoid glucose-containing solutions, and also to check the blood glucose frequently and correct if the blood sugar falls below 3.5 millimoles per liter. In summary, epilepsy surgery in children is an important tool. Detailed workups required and often entails anesthesia for younger children. There are specific considerations in epilepsy surgery, particularly if doing ECOG and if they're on a ketogenic diet or very young. but successful treatment changes the natural course of the refractory epilepsy and is life-changing. So thank you very much.
Okay, thank you, Dr. Chan, for this in-depth discussion of the considerations of epilepsy surgery in children. Okay, the advances of neuroimaging and surgical techniques have made epilepsy surgery safer and can give your child a lasting relief. Okay, for our poll question, pediatric anesthesia considerations in epilepsy surgery include avoiding interruption of maintenance anti-seizure medications when nil by mouth. Number 2, appropriate planning for blood loss and replacement during large resections such as hemispherectomy, particularly in small children. Avoiding medications which may exacerbate blood loss or promote cerebral hemorrhage. And number 4, selection and timing or use of anesthetic agents compatible for electrocorticography if performed. And last, number 5, advanced planning for intravenous fluid selection, frequency of glucose monitoring, and correction in patients on the ketogenic diet. Letter A, only 1 and 2. The answers are, you could choose letter A, only 1 and 2. Letter B, 2 and 4. Letter C is 2, 3, and 4. And letter D is all of the above. You are given 30 seconds to answer the question and submit your answers to the poll. Okay. Can we call on Dr. Chan to proceed or to answer the question and give a short discussion on the answer? Okay, Dr. Chan.
Thank you so much.
Back to you.
So actually the answer is all the above, right? So if you've so apologies a little bit, the sound did skip a little bit on the slides, but essentially all of those things are very important aspects of planning for the patient who is undergoing pediatric epilepsy surgery. So like I stressed, first of all, maintenance anti-seizure medications, you really don't want to stop them or interrupt the administration of them. If they're nil by mouth, you give it either through an IV form or you give it through an NG tube, or you give it before or after the surgery to make sure that, you know, they got their daily dose, basically. Blood loss and replacement is a major factor in smaller children. That's why we don't actually do epilepsy surgery below 3 months, because the volume they need to lose to get into a lot of trouble is very, very small. And, you know, a hemispherectomy, you're taking out half a brain. So that's a lot of risk for blood loss there. So we do try to get them above a certain weight. We will consult our neurosurgeons and ask them what's their comfort level for the minimum weight and the minimum age for doing surgery. And medically, no matter how bad the epilepsy, we will really try to just hold off until they've had a chance to grow to a stage where it can be done safely. And 3 kind of alludes to 2, basically, the blood loss kind of issue. As you heard, we talked about the electrocorticography. There are many anesthetic agents, and some of them increase spiking, some of them actually suppress spiking. So it's actually important to choose the anesthetic agents which don't adversely impact on the recording. Otherwise, the epileptologist can't delineate the electrographic area, and then the surgeon can't decide where to reset. So there was a question in the chat about using sevoflurane, and actually, if you look in the literature, there are papers that say that sevoflurane actually suppresses spikes. And then, of course, ketogenic diet. If the patient's on the ketogenic diet, they're on a very, very low carbohydrate diet. So basically, it's very easy for them to flip into hypoglycemia. So it's really important that, you know, first of all, you don't give them a lot of glucose, because then they are no longer on the ketogenic diet. and that's like pulling somebody off their medicine, in a hurry. So we don't want to give them glucose-containing solutions because it'll reverse the ketogenic diet, the ketosis that they're supposed to be in. But at the same time, we don't want them to be dangerously hypoglycemic. So we need them to be on dextrose-free solutions, but monitoring very closely on the glucose and then replacing in small boluses if they go hypoglycemic.
Okay, Dr. Chan, thank you so much. If you have other questions, you could submit them to the question and answer box, and we will direct these questions to the speakers after the forum. Okay, moving on to our next speaker is Dr. Jaya Ganesh Virakumaran. Did I pronounce your name correctly, Dr. Jaya? Okay. Dr. Jaya is the neuroanesthetist at the University of Malaya and Medical and Specialist Center. He is the treasurer of the Malaysian Society of Neuroanesthesia and Critical Care and fellow and member of the Indian Society of Neuroanesthesia and Critical Care. His interest includes image-guided minimally invasive surgeries, wake and functional surgery, motor sport medicine. So to give talk on the awake craniotomy in children, may I call on Dr. Jaya? Okay, take it away, Dr. Jaya.
Good evening. Thank you, ASPA, for this opportunity to talk. I'll be talking on awake craniotomy in children, the unknown. Little boy A presented to us with 2 episodes of left-sided focal seizures. At the time of presentation, he was only 16 years old with no other symptoms. An MRI showed a right temporal parietal insular low-grade glioma. He was planned for awake surgery due to the site of the tumor. And he was quite a mature child, and he was otherwise a very well child till the day he presented to us. This is the scan that was taken pre-operatively before we actually decided to take him in for an awake craniotomy. If you can see, look at the scan, the site of the tumor is not fairly difficult. It is something that the surgery would take us maybe about 2 hours. Okay, in an overview, what is awake craniotomy? Awake craniotomy is a surgical procedure in which the patient is deliberately kept awake during the whole surgery process or a portion of the surgery. During this time, he will be able to communicate with the operating team, with the anesthetist, with the surgeon, or with the neurophysiologist, and able to perform tasks that was already actually pre-planned and told to him. Awake craniotomy allows maximized tumor resection while preserving the vital neurological functions of the patient. So why is awake craniotomy done? Awake craniotomy is done when the tumor involves vital or important parts of the brain motor cortex and language cortex, where usually imaging is not sufficiently sensitive. And while doing awake craniotomy, we can also facilitate electrocorticography for seizure focus localization and resection, as it minimizes the interference of anesthetic medication. Other conditions where awake craniotomy is also being used is during deep brain stimulation for Parkinson patients and for other neurological disorders. Awake craniotomy sometimes is also used in stereotactic brain biopsy or in a patient for ventriculostomy. Other benefits of awake craniotomy is like avoiding the risk of general anesthesia. Most patients that come in for general anesthesia for craniotomy will have certain amount of post-operative delayed awakening, nausea, vomiting, and also awake craniotomy reduces the need of extensive monitoring in ICU and therefore reduces the length of hospital stay. And this, in a long run, will also reduce the cost of hospitalization. Patients undergoing awake craniotomy have usually found to have a fewer neurological deficits post-operatively. So what are the absolute contraindications for awake craniotomy? Number one is patient refusal. Patients who refuse for this procedure should not be forced into undergoing it. Number two, unable to lie still or flat for a length of time. For an example, patients with cardiac failure may not be able to lie still or flat for a long time. Patients who are unable to cooperate due to any reasons, may be due to the pathology itself or other related medical conditions like dementia. Other relative contraindications for this procedure is patients who are obese with difficult airway and with medical related disease like OSA. Huge tumor, vascular tumor, again, may be an absolute contraindication for awake craniotomy. Tumors requiring difficult positions, which may not be suitable for the patient to stay or lie still for a period of time, again, may be considered not a suitable candidate for awake craniotomy. Young patients who are not matured may be again a relative contraindication for awake craniotomy. There are three basic parts in patients undergoing awake craniotomy: the pre-awake stage, the awake stage, and the post-awake stage. The pre-awake stage is where the Mayfield pin clamps are applied. Skin incision is done, the removal of bone flap, and the incision of dura mater. At this stage, the surgical stimuli or pain may be more than the main procedure itself. Then comes the awake stage. In the awake stage, the patient has to be awake because this is where the neurophysiology monitoring, brain mapping, and tumor resection is done. This stage usually takes about 2 hours because most of the monitoring will form certain amount of stress or discomfort to the patient. And lastly is the post-awake stage where there is closure and replacement of bone flap is done. At this stage, the patient most of the time is sedated or kept back asleep. So what are the anesthetic methods available for patients undergoing awake craniotomy? There are basically three methods that are well known for this procedure: the sleep awake sleep method, the sleep awake awake method, and awake 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 method, right? A sleep method can be usually achieved by giving general anesthesia with endotracheal intubation, LMA, laryngeal mask airway, or monitored care anesthesia. In our center, we usually do most of our patients with monitored care anesthesia. What are the points to consider for awake craniotomy in a child? Number one is child maturity. Is or does the child mature enough to understand the procedure that is going to be done and the task required for he or she to do during the procedure? Number two, duration of operation. A child may not be cooperative for too long period of time. So if the operation may take a longer time, then this might not be a suitable candidate. Vascularity of the tumor. Is the tumor vascular? If the tumor is vascular, located in a difficult position, and a lot of blood loss is expected, then again this may not be suitable for awake craniotomy. Position required. If the position required is difficult or uncomfortable, then again the patient may become restless after some time. And lastly, pain. Is the position or the type the surgery plan is painful? If it's painful, again, a child's pain threshold may not be too good. So how did we approach this kid? Firstly, and the most important aspect is approaching the child and assessing if the child is matured and is the child able to accept the idea of awake craniotomy. Secondly, a multidisciplinary discussion involving the parents, the surgeon, and the neurophysiologist is important. All available options must be discussed with the parent, and advantages and disadvantages of each method must be explained to the parents. Only if the parents accept this method of surgery, then we can proceed to the next step. Once the idea of awake craniotomy is accepted by the parents, detailed explanation of the procedure will be done. Consent taking is the next important part. And since it's a child, most of the consent taking must be done by the parents. So a written consent must be taken from the parents after a detailed explanation is done together with the parents and patient. All possible events must be explained and told. A tour of the operation theatre must be done to reduce the anxiety of the patient and parents. A child sometimes or was made to sleep in the operation table to plan the position to make sure the patient is familiar with the position. The child then will be allowed to bring a toy or a game of his favorite during the time of surgery. All the intended neurophysiological monitoring that is going to be done to the patient must be explained and told to the child, and all the functions must be assessed baseline prior to the operation. So how did we prepare this child pre-operatively? Number one is fasting. We kept the child fasting for only 6 hours with 2 hours of clear fluid. The child was done as the first case in the morning. This is important so that the surgeon, anesthetist, and the patient is fresh in the morning. It may be good to have the child to get a bath in the morning to be fresh and alert during the time of surgery. It's advised for the child to empty his bladder before being wheeled down to the operation theatre. Intraoperatively, or the pre-awake stage, how did we go? Number one, avoid excessive cannulations. We only cannulated the patient with a single large bore brenula. Number two, avoid CBD. Insertion of CBD may be uncomfortable to the patient and may result in patient restlessness. Number three, temperature of the operation theatre. We usually keep the operation temperature slightly higher so that the patient doesn't feel cold and become uncooperative. Number four, allow the patient to continue to play his favorite game or listen to some music. This may allow the patient to relax himself and to distract the patient from the actual procedure. Number five, maintain minimal sound in the operation theatre. Every staff in the operation theatre must be advised to keep minimal discussion and not to discuss other irrelevant things. Number six, maintain communication with the patient. Explain step by step what is happening or going to happen to the patient. The brenula cannulation is usually done on the opposite side hand so that this doesn't interfere with the neurophysiologist monitoring. And then the patient is usually given a nasal oxygen cannula to be started with. Sedation then will be started in the reception before the patient can be wheeled into the operation theatre. In our center, we use remifentanil and dexmedetomidine target controlled infusion to the patient's response. Routine non-invasive monitoring will be applied, and the most important thing is respiratory rate monitoring. We usually avoid invasive arterial lines or CVP lines as this may cause pain and uncomfortableness to the patient. This monitor is applied once the brain navigation is completed. Once the patient is placed on the operation table, the skull block will be done and given bilaterally using plain marcaine diluted to 0.25% with some lignocaine added and calculated dose to the patient's body weight. The pin site then will be identified and the clamp must be applied gently after local anesthesia being given. Local anesthesia will also be given at incision site and just before incision of dura. During this initial part, we will maintain the patient on a slightly deeper targeted sedation based on our BIS response and patient response. Remifentanil will be kept minimal during this procedure with a TCI target control around 0.3 to 0.5 nanogram per ml. Usually, pain will not be so bad as skull block and other local anesthesias will be supplemented as well. Presidex was then titrated between 0.4 to 0.6 micrograms per kg in this initial phase and then reduced according to patient's anxiety and restlessness. We usually combine these two drugs to reduce the risk of apnea. In the awake stage, 15 minutes before this stage, the sedation will then be gradually reduced till a good communication is established with the patient. Cortical and subcortical mapping was done by asking the patient to tell his name, address, parent's name, and identify objects that was shown to him to record the baseline reading. Motor functions was then tested by asking him to move his thumbs and touch the fingers. The motor tracks were noted medially. The patient must be then kept comfortable during this period so that subsequent testings will be able to be done. Once the brain mapping is completed, the resection was started and from time to time testings was done and communication was maintained with the patient. During resection, blood loss is kept minimal and all discussions between staff must be done quietly to reduce patient anxiety. The patient was allowed to continue to hear his music during the testing and sedation was gradually increased. We kept our resection time to about 120 minutes. We used goal-directed fluid management to reduce brain edema and to avoid bladder discomfort, which may lead to restlessness and discomfort to the patient. Our choice of fluids was balanced solutions like sterofundin. In this procedure, we achieved a subtotal resection of tumor due to the functional tissue located within the tumor. At the post-awake stage, brain closure was done, and at this stage, we usually increase our sedation, but the patient will be allowed to sleep or comfortably play or listen to music. Pain during dura closure was avoided by giving some supplement local anesthesia again. Skin closure may be painful and therefore addition of local anesthesia may be needed. A post-operative MRI was done and the patient was then transferred to the recovery bay. This is the post-operative scan taken for the patient after the operation was done. So in conclusion, awake craniotomy in children is possible provided the child is matured and cooperative. Proper counseling must be done to the parents and patient pre-operatively to reduce anxiety. All possible steps must be taken to reduce anxiety and to reduce restlessness of the patient. A multidisciplinary approach must be taken from the beginning. All details of surgical planning with the use of brain navigation is important to reduce operation time.
Okay, thank you, Dr. Jaya, for the very extensive presentation on awake craniotomy in children. Now, our poll question is, what is the most important point to consider before considering awake craniotomy in a child? A, size of the tumor. B, the child's level of maturity. C, vascularity of the tumor. And D, the child's body weight. Okay, you're given 30 seconds to answer and submit your answers to the poll. Okay, I'm giving back the floor to Dr. Jaya to discuss on the answer. Okay, Dr. Jaya.
Okay, good evening, everyone. Well, like I said in my earlier slide, I think the most important thing that we must consider in before a child can be considered for awake craniotomy is the child's maturity. And every child's maturity actually is different, and it doesn't really depend on the child's age. Some child may be young, some child may be 15 years old or 14 years old, but their level of maturity will be equivalent to a 17 or 18-year-old. So I think the most important thing before we can consider awake craniotomy in a child is to look at the child's maturity and see whether the child can understand what procedure he's going to go through, what to expect, and how to go about it. Of course, like the other answers, the size of the tumor, vascularity of the tumor, and the child's body weight, all the other considerations that we have to take into before we decide for awake craniotomy in general for patients. I hand over back to Dr. Michi.
Do you have other questions? Okay. Again, awake brain surgery in children remains a subject of controversial debate for the potential psychological limitations that are related to the type of procedure. Okay, thank you, Dr. Jaya. Now, moving on with our third speaker is Dr. Karen Adapon Saho. Dr. Adapon is the head of the neuroanesthesia section of the Rizal Medical Center, Pasig City, Philippines. She's also a clinical professor and active consultant at the University of the East, Ramon Magsaysay Memorial Medical Center. She is a research associate in the Department of Anesthesia at Las Piñas General Hospital Trauma Satellite Center. And her interests includes pediatric anesthesia, pediatric neuroanesthesia, and spine surgery. Okay, Dr. Adapon, you can have the floor now.
Good afternoon, everyone. Today, let's unravel your knowledge about pediatric aneurysm anesthetic considerations. I would like to disclose that I have no conflict of interest in delivering this lecture, and the objectives of this lecture are the following. We will define pediatric intracranial aneurysms, or PIA, incidence of pediatric intracranial aneurysms, anesthetic considerations for intracranial aneurysms in children, and lastly is to discuss about post-operative care management in intracranial aneurysms in children. Let us start with a take-off case with a 6-year-old male underwent bifrontal craniotomy, clipping of ruptured aneurysm, evacuation of hematoma, with a chief complaint of headache of 10 days duration. History of present illness started with a history of head trauma due to vehicular accident. Patient was subsequently admitted at a nearby hospital in the Philippines, and the CT scan result no acute intracerebral hemorrhage. He was cleared and discharged after 3 days with no noted symptoms. Until 9 days prior to admission, patient was noted to have rolling of eyes, stiffening of body associated with fever and headache. CT scan result revealed a resolution of subgaleal hematoma with subcutaneous emphysema. He was then given ibuprofen and was discharged thereafter. There was no recurrence of headache, fever, and seizure. Until 1 day prior to admission, patient complained of severe headache associated with 1 episode of non-projectile, non-venous vomiting of previously ingested food. He was noted to also have decrease in sensorium that led to gasping, and he was subsequently intubated and admitted at the hospital. So what are pediatric intracranial aneurysms? There are 2 types, your traumatic and your non-traumatic. Your traumatic subarachnoid hemorrhage results from the tearing and weakening of intracerebral blood vessels, resulting in intracranial aneurysms due to the force of trauma, while your non-traumatic cerebral subarachnoid hemorrhage is due to the deficiency of a necessary protein essential for arterial wall functionality. Your highest incidence during early childhood is your middle cerebral artery and your vertebrobasilar system. Several literature review revealed that age incidence, associated conditions, such as coarctation of the aorta, your Ehlers-Danlos syndrome, Marfan syndrome, polycystic kidney disease, fibromuscular dysplasia, tuberous sclerosis, as well as prevalence of hypertension, atherosclerosis, histology and electron microscopic structure of childhood cases, early damage from hypertension, birth injury, trauma, and in utero insults may play a significant role in the development of cerebral aneurysms in the pediatric population. They concluded that a purely degenerative pathogenetic model could explain aneurysm formation in children. Carotid bifurcation aneurysms are also found in 29 to 54% in carotid bifurcation of all childhood cases, as compared to 4.4 to 4.5% of all aneurysms in adults. And mostly, 62% of giant aneurysms occurred in boys. Therefore, there is a male predominance in children. Incidence is around 3 to 4%, and 1 to 3 cases of childhood aneurysm per 1 million population. The ratio in childhood cases is around 1.3 to 2.8:1 male to female ratio. And the trauma-induced aneurysmal development is the most common cause of subarachnoid hemorrhage in the pediatric population. Now, what do we do during patient assessment? It is important to highlight here that patient had an MVA several days prior to subsequent admissions. General description for this patient. Patient has fever, generalized weakness, and generalized seizure as well. It is also important to highlight here that patient is drowsy but obeys verbal commands, in respiratory distress and intubated. Patient had mild focal deficits with a Hunt and Hess grade 3, moderate to severe headache, drowsy with mild focal deficit. Okay, and Hunt and Hess purpose is to predict prognosis and outcome in patients with subarachnoid hemorrhage. So a higher grade predicts a poor outcome and lower likelihood of survival. Poor prognosis is grade 4 and grade 5. So for this patient, he has a moderate to severe headache, drowsy with mild focal deficit, and is considered Hunt and Hess grade 3. So what are our preoperative preparations? First is to have multidisciplinary conference of the different subspecialties and parents. Patient's BP should be controlled prior to procedure. You may use calcium channel blockers, beta blockers, and vasodilators for pressure control. Anti-seizure medication given and continued, such as your levetiracetam. Blood products availability were secured, and post-op ICU with standby mechanical ventilation were also ordered. Now, what are our goals in anesthesia? Of course, you have to have a smooth induction and hemodynamic control during intubation, placement of scalp block. Propofol and remifentanil attenuates hemodynamic response and rebleeding risk, and dose reduction may be required as induction hypotension can compromise cerebral perfusion. These are the scalp block that I use to block for children, and I use a dose combination of bupivacaine and lidocaine, and this dosing is based from the computed toxic dose. With a weight of 21 kilo, I have used 4 cc bupivacaine plus 4 cc lidocaine without epinephrine. And this is very useful in head pinning and for post-operative pain as well. Now, intraoperatively, what I try to attain here is how to optimize our cerebral perfusion pressure and oxygen delivery. So how do I achieve this? Well, of course, using TIVA technique is one key because it does not increase your cerebral metabolic rate oxygenation in TIVA technique as compared to your inhalational, in which your cerebral blood flow increases, resulting to increased ICP. And additionally, your propofol, because of its favorable hemodynamic and physiological properties, propofol remains one of the most commonly used anesthetics for neurosurgical procedures. It decreases your cerebral blood flow, your cerebral metabolic rate oxygenation, and ICP, and has been shown to have neuroprotective effects. And also, expecting a sudden loss of blood in this type of surgery, so multiple IV lines and arterial lines are helpful. And we have to make sure that avoiding large swings in BP are essential for the good outcome of this patient. Now, the propofol-based TIVA, based on this study by Mohammed Ghanem, okay, has better cerebral oxygenation profile, better cerebral lower jugular oxygen saturation as compared to your sevoflurane-based inhalational anesthesia less than 1 mAh, which improves cerebral blood flow statistically during cerebral aneurysm clipping surgery. Now, for this patient, okay, I have used pedfuser mode in propofol with a maintenance of propofol 2.5 to 4 mics per ml, remifentanil loading dose at 2 mics per kilo per minute over 2 minutes, and the maintenance was used of 0.1 to 0.15 mics per kilo per minute. And vital signs were maintained between 120 to 140 over 60 to 80 diastolic BP, heart rate of 90 to 110, O2 sat of 100%, and a loading IV drip over 20 to 25 minutes of morphine at 0.1 milligram per kilo, 40 minutes prior end of surgery. This patient was extubated 6 days post-surgery, and pain was well controlled as well. So what are the benefits for TIVA technique? As I said, it reduced post-operative nausea and vomiting, quicker recovery, improved quality of recovery, reduced airway reactivity, improved neurophysiologic monitoring, and less operating room pollution. In one study published by the British Journal of Anesthesia 2020, through these stimulations, they have concluded a plasma target concentration of about 4 mics per ml in remifentanil are consistent with the recommended initial doses for all age groups from FDA and European Medicine Agency or EMA. And the recommended maintenance dosing of remifentanil in adults is 0.05 to 2 mics per kilo per minute, while in children is 0.05 to 1.3 mics per kilo per minute. And this very wide range have likely indicated the desire of the regulatory authorities to allow individualized dose rates. It was also noted that TCI remifentanil in pediatrics using the Minto effect results in significant hypotension and bradycardia in pediatric population. And we all know that remifentanil used to be off-label from 12 years old below based from TCI guidelines and used to be off-labeled by FDA guidelines from 18 years old and below. But now, this is the recommended dosing of the regulatory authorities for individualized dose rates and US FDA approved drug label for neonates and children for remifentanil. It is considered maintenance infusion rate is adequate if they were 30% of the recommended value, and all models were tested over the whole population, which means that the Minto models were tested outside of their intended population, and that is in children. This is the reason why Minto models are not being used in children. In this journal entitled Practicalities of TIVA and TCI in Children, it reported that the rapid development of mu receptor tolerance with remifentanil are in conflict, and activity at sigma opioid receptors may contribute, suggesting that large doses of remifentanil may cause tolerance. In fact, it was noted that more postoperative fentanyl was given at 24 hours in those who received 0.6 or 0.9 mics per kilo per minute than those who receive a lower dose of remifentanil, suggesting that large doses of remifentanil may really cause intolerance. Similarly, adolescents undergoing spinal instrumentation for scoliosis also demonstrated acute tolerance. So it has been suggested that longer-acting opioids such as morphine be administered approximately 40 minutes before the end of surgery to allow time for it to bind to opioid receptors occupied by remifentanil. And this morphine dose timing is consistent with the equilibration half-time between central and effect compartments for morphine of 16 minutes. So what other challenges can we encounter intraoperatively? First, challenges from a full brain. And brain laxity is crucial to obtain good surgical access to the aneurysm and from excessive retractor pressure. And this is important as early surgery risk a tense or full brain, and dissection without adequate exposure can result in complication. So a 3% hypertonic saline, furosemide, mannitol, or osmotic agents for intraoperative brain relaxation with a pediatric dose of 0.5 to 1 gram per kilo are also helpful in this kind of challenges that we have encountered. So if full brain persists, additional measures like moderate hyperventilation, avoiding jugular compression, avoiding high concentration of inhalational agents, mild hyperventilation, using pure TIVA technique, and the release of CSF are all helpful via epidural lumbar drain in solving the challenges from a full brain. How about the challenges from vasospasm that we have encountered? Okay, for this type of problem that we have encountered during the operation, I have used volume expansion, okay, hyperdynamic therapy with pressures and inotropes, and hemodilution. I rarely use nimodipine in addressing vasospasm in children since several literature have been discussed and that angiographic vasospasm is less common in children with rare clinical progression, and experience with nimodipine in children with subarachnoid hemorrhage is limited. So the use of this volume expansion and urotherapies and hemodilution should be instituted instead. Based from one literature study by Josh Efren, in which they have recorded those children with confirmed subarachnoid hemorrhage who have received oral nimodipine at 1 milligram per kilo every 4 hours from year 2005 to 2013, the results showed that it is associated with a high rate of hypotension requiring intervention or dose modification, and that evidence of vasospasm was still observed in 67%. With that, they have concluded that the nimodipine does not really eliminate vasospasm, rebleeding, or infarction, and is associated with a significant hypotension. So what other modalities can we use? Okay, we could use your magnesium, which just considered a neuroprotective agent. So whatever it's worth, I also consider giving this in patients with whom severe clinical vasospasm are evident. Why? Because you'll be surprised that it actually suppresses excitatory amino acids, such as your glutamate and aspartate, which are being released during your traumatic brain injury. It can cross your blood-brain barrier and it is considered a cerebral vasodilator that blocks your sodium voltage-dependent calcium channels and NMDA channels, which reverses vasospasm. Okay, aside from that, it also suppresses excitatory amino acids, attenuates brain edema and improves neurologic recovery, and works at the postsynaptic receptor to reduce the neurotoxic effects of glutamate, and is found to attenuate brain tissue hypoxia during temporary occlusion. So for magnesium, the dosing in children is around 25 to 50 milligram per kilo, diluted in 20 cc every 6 hours to run for 1 hour. For this patient, we have given one dose of 30 milligram per kilo to run for 1 hour intraoperatively. Now, other challenges I have encountered with this procedure was during temporary clipping as well. And it's important to provide a moderate hypertension to improve collateral blood supply by increasing your cerebral perfusion pressure and maintaining a MAP of 75 to 80. In one post-hoc analysis by Hindman consisting of 441 patients who underwent temporary vessel occlusion, they found the temporary clip duration of greater than 20 minutes are less favorable, favorable neurologic outcome. And as it may not always be possible to adhere to this timeline, cerebral protective measures may be required, such as induced hypertension or suppression of cerebral activity with hypothermia, or pharmacologic agents would help reduce cerebral metabolism and improve tolerance to ischemia. Okay. In addition, passive hypothermia may be permitted and BP maintained 20% above the pre-clip level. So with this patient, the child came in with ruptured of aneurysm already. But what do I usually do for an unruptured case and suddenly ruptured intraoperatively? A transient low normal BP may be permitted if intraoperative aneurysmal rupture occurred during clip application. Okay, and intravascular volume resuscitation with isotonic fluids and blood products should be aggressively pursued. Also, pharmacological protection may not be feasible during intraoperative aneurysm rupture when both your intravascular volume and BP is very low. Now, the monitorings that I use during aneurysm surgery is your SSEP. As you can see, it has been helpful since somatosensory evoked potential has been used to predict postoperative stroke or neurologic deficits in patients undergoing aneurysm clipping, and less than 15 ml of 100 grams per minute or regional cerebral blood flow, SSEP amplitude to 50% of baseline. Okay, so your SSEP monitor basically helps in detecting effect of changes in the anesthetic depth, your temporary vessel occlusion, hemodynamic changes, and surgical manipulation. It also allows detection of cerebral ischemia, which facilitates timely corrective measures and predicts postoperative neurologic deficits. In one study on 691 patients, they found that in unruptured aneurysms, irreversible SSEP changes were associated with 80% stroke rate, and in ruptured aneurysms, irreversible changes were associated with 42% stroke rate. Now let us go to another monitoring, which is our motor evoked potential, which are sensitive in predicting motor deficits following aneurysm surgery with permanent loss of motor evoked potential predicting postoperative motor impairment. And thus, muscle relaxation should be avoided during your MEP monitoring. Okay, for your non-invasive monitoring, your BIS Connox monitoring facilitates and guides in the identification of your lower limit of cerebral autoregulation during aneurysm surgery and help maintain safe level of BP to prevent ischemic insults. Ideally, your cerebral oximetry would also serve as a guide between an adequate balanced cerebral oxygen supply and demand. For your post-clipping evaluation, another challenge during aneurysm is to ensure non-inclusion of normal vessel or perforators within the clip and perform complete aneurysmal isolation. So I do this with the use of intraoperative ICG, okay, and which are very simple and safe. And because it assessed the vessel patency and aneurysm obliteration in 93.5% of patients. Okay, you just have to be cautious because the effect could be transient oxygen desaturation. So, in conclusion, in one study observed that clip repositioning was required based on IMD findings in 24% of aneurysms clipped in 91 patients, and that your IMD could reduce the rate of residual aneurysm and unanticipated vessel stenosis. So our hemodynamic goals post-clipping, BP must be maintained about 20% above the pre-clipping range to maintain cerebral perfusion through the spastic vessels and reduce ischemic complications. Normovolemia, CVP of 10, and normal oxygenation, such as hemoglobin of 10 grams, is desirable. And of course, your effective glycemic control and management are important because you have to avoid hypoglycemia because it could affect the outcome of the surgery. Okay. As you can see, uncontrolled glucose level was associated with long-term changes in cognition and gross neurological function. The indications for your post-operative ventilation, okay, is poor preoperative subarachnoid hemorrhage grade, prolonged temporary vessel occlusions, severe intraoperative vasospasm, and if you have a major blood loss of greater than 50% of the allowable computed blood loss. Okay, this is the time that we decide when to place the patient in mechanical ventilation post-op. So in summary, preoperatively, you have to avoid pre-op sedation, prevent hypocarbia, to prevent further cerebral ischemia. If there's clinical vasospasm, use of volume expansion, hyperdynamic therapy with pressures and inotropes, and hemodilution should be instituted. Blood products availability and multidisciplinary conference are essential. Intraoperatively, ensure adequate depth of anesthesia for invasive maneuvers, such as your intubation, scalp block, and head pins placement. Reduce cerebral edema with moderate hyperventilation or osmotic diuresis. Okay, continue the anticonvulsants therapy throughout the perioperative period, and make sure that you will have rapid emergence from anesthesia so that it will allow the surgeon to perform a complete neurologic exam shortly after surgery. Post-operatively, it's important to have normovolemia because the prophylactic induced hypervolemia is ideally not recommended anymore. Okay, the RCTs to date demonstrated volume expansion increases the rate of medical complication without improving overall outcome or reducing your cerebral ischemia. Ensure that indication for post-operative mechanical ventilation has been thoroughly reviewed and reassessed before immediate extubation post-op. Optimal post-operative pain control and sedation while intubated post-op are essential as well. So remember our goals: hypertension, target BP of 110 to 120, or CPP greater than 70 to 80. Start nor-epi if BP goal is not achieved with fluid boluses. And for normovolemia, IV fluid should be continued at 1.5 times maintenance for 48 to 72 hours. Keep CVP between 8 to 10 millimeter mercury. And for hemodilution, do not transfuse blood if hemoglobin is above 10 grams per deciliter or hematocrit 30 to 35%. Lastly, for a recommendation, all patients with completely clip aneurysm should be started on normovolemia. okay? As well as control of your BP prior and during the procedure. Okay, achieve a child's BP to 95th percentile. Placing invasive arterial BP monitoring, CVP if you can, temperature probe, large bore peripheral lines, placement of NGT and Foley catheter are also essential. Use of monitor assessing anesthetic depth or consciousness, intraoperative neuromonitoring to optimize neurophysiological recordings, and a multimodal regimen for optimal postoperative pain control and sedation while intubated post-op are also advocated. Multimodal postoperative nausea and vomiting are also essential. And continuation of your anti-seizure medication antibiotic is necessary. CBG monitoring Q2 to Q4 are highly recommended as well. This diagram depicts what the primary goals in the anesthetic management for unruptured aneurysm. And this is a flow diagram, how acute ICU or intensive care should be offered to all patients with subarachnoid hemorrhage. And acute phase monitoring and treating symptomatically to avoid complications are the goals. And lastly, this figure shows a schematic guide of subarachnoid hemorrhage diagnosis and management according to current literature. As you can see, the CT scan is performed for initial screening for suspected subarachnoid hemorrhage, and the consequent algorithm represents treatment options and monitoring strategies which are currently the standard of treatment. With that, this ends my lecture. Thank you for listening. These are my...
Okay, thank you, Dr. Saho, for the very comprehensive discussion on the considerations of AV malformation and aneurysm clipping in children. Now, can we have our poll question? Okay, I'll read on the poll question. For our 6-year-old patient with a ruptured aneurysm, what is the goal after temporary clipping of aneurysm? Single choice. A, induced moderate hypertension. 2, B, induced hypotension. C, induced hypotension. Oh, and C, D is normotension. What's this? None of the above? The last is none of the above. Okay. 30 seconds to answer this poll question. Okay, I'm giving back the floor to Dr. Saho to explain or give light on the question, the poll question. Okay, Dr. Saho, please.
Yeah, so the answer for this question is letter A. Okay, so because we need to induce moderate hypertension. Why? To provide collateral supply to adjacent brain structures to avoid cerebral ischemia, and to avoid induced hypotension to prevent cerebral ischemia. So the answer here is letter A.
Okay, Dr. Sao, thank you very much. So, if you have further questions, you can direct your questions to the question and answer box, so our speakers will answer them after this forum.
Thank you very much for that very informative talks to our speaker. I think we can formally open now our panel discussion. May we invite all our speakers to turn on your video, and we will direct some questions shared in our Q&A box. I think there's a lot of questions. Our speakers have kindly answered most of them in the Q&A box, but we still need to ask a few questions. Maybe we can direct the first question to Dr. Derek. Yeah, hi, Dr. Derek. Good afternoon. Thank you for your talk earlier on. So there's one question about, actually there are two questions regarding muscle relaxants in epilepsy surgery. So you mentioned earlier on that as much as possible, we try to avoid muscle relaxants. Is that particular a stage of the surgery? Can we use muscle relaxant?
Certainly. Yeah, I don't think we're saying don't use muscle relaxants. Obviously, that's not a very easy thing to do. But if we know that we're going to do motor mapping particularly, then what we do is we stimulate at the cortex, right? And then Actually, the anesthetist is usually looking at the hands and to try to tell us whether or not bits of the body are moving. So a short-acting muscle relaxant early on is fine, but nothing that's long-acting, and definitely not like in the probably 20-30 minutes before we're going to start mapping. So that's how we do that.
Yeah. Thank you very much, Dr. Derek, for that question. Another question is that how do you manage intraoperative seizures? Are you going to use like just a cold saline irrigation? And how often do you need to give anti-seizure medications during the surgery?
Yeah.
I understand sometimes you go inside the operating theater with us, and
Yeah.
in the event that there is a seizure episode, maybe you've seen it in the EEG or in the monitoring, what should we do then?
Yeah, I'll take a page. Oh, if any of you ever read Hitchhiker's Guide to the Galaxy, then the answer is don't panic.
All right.
So essentially, I mean, remember, these kids have been having seizures for many years, right? And the goal of the surgery is that, of the monitoring, is to identify where these areas are. So we don't want to unnecessarily suppress the seizures. If it's going on too long, yes, cold saline is a good solution. But if they're short seizures, we will actually use those to actually help us to mark out the epileptic area and therefore to tune the resection. So yeah, we really don't want to give like lots of medications intraoperatively to suppress those.
Yeah. Thank you very much, Dr. Derek, for clarifying and giving us some inputs regarding intraoperative seizure. I have another question. This one is for Dr. Jaya, addressing a question to Dr. Jaya. There are some of our anesthetists are asking during awake craniotomy. You mentioned about not inserting an arterial line. So we're just wondering whether can the arterial line be inserted if you are in a sleep awake asleep or asleep awake awake. Can you put the arterial line during the asleep stage, or do you really do not insert any arterial line for your awake craniotomy because you think that it is uncomfortable for our patient?
Well, like I said earlier, before we decide on putting any invasive lines, we should see the real indication of inserting the line. So like in my earlier slide, I said the contraindications and absolute and relative contraindications there. If you really think that this tumor is a huge tumor, it's going to bleed, it requires arterial monitoring and more invasive line monitoring, maybe then we should reconsider whether this patient is really suitable for awake craniotomy in the first place. But of course, I would say if you intraoperatively, if there is bleeding or you encounter problem intraoperatively, then of course arterial line can be inserted during the pre-awake stage, right? And monitored during then. During the awake stage, putting in an arterial line might be a bit challenging, as the patient will be very uncomfortable and pain and restless. And if we encounter any problems like bleeding or seizures or anything that we can't control intraoperatively, of course, we must always have our GA anesthetic machine as our backup for us to fall back to in case we run into any problems. Yeah.
And you will always be prepared to convert anytime. Yeah, correct. Yeah. Thank you for clarifying, Dr. Jaya. So I have another question. I think I need to go back to Dr. Derek again. There's one question from Dr. Hatis from Turkey. What are your suggestions for early detection of anti-epileptic related metabolic problems in children receiving multiple anti-epileptic treatments? Dr. Derek?
Yeah. So I think I suspect the questioner's referring to certain things like, carbamazepine can cause hyponatremia, topiramate can cause a mild metabolic acidosis, valproate can cause hyperammonemia and transaminitis. And I think the answer to that is actually that the epilepsy physician should be monitoring those all along, periodically along the way. So we should be taking that into account and correcting for that, or monitoring those before it becomes the anesthetist problem. It shouldn't suddenly be a finding at the point of anesthesia. So like carbamazepine, if they are hyponatremic, we have to dose reduce, no choice. And valproate, if they have hyperammonemia and transaminitis, we need to give them levocarnitine and may have to cut the dose as well. And you can get thrombocytopenia as well with valproate. So, and that's dose dependent. So, you know, and then that pushes us more actually to need to do the epilepsy surgery, because now the side effects are actually limiting our ability to treat the seizures.
Yeah. Thank you for your input. Very informative, Dr. Derek. Yeah. Next question is Dr. Karen. Hi, Dr. Karen. Thank you for your lecture. One in your poll question answer, right, is about induced hypertension. There's a question here that what drugs you usually use to induce hypertension or to maintain that blood pressure targets that you set early on during your presentation. I understand you use like what vasopressors do you use, or do you give volume first? How do you do it?
Of course, we give volume first, but if it's not working anymore and you still have hypotension and the target range of MAP is not attained, of course, we have to convert to a higher dose of using pressure. So aside from norepinephrine, you could use your dopamine, okay? And then, if not for infusion or during like temporary clipping of aneurysm, you could use a low dose of your ephedrine as well.
Yeah. Okay. So will you use phenylephrine or ephedrine? Which one do you prefer actually for vasopressors if you need to give anything?
Well, we have to maintain a balance between the heart rate and the BP. So if this patient is becoming tachycardic and then hypotensive, of course, you have to use your phenylephrine.
Yeah, I see. Thank you very much for that. Same question. I am Dr. Jaya. Have you done any aneurysm clipping in your practice as well? Do you actually also advocate induced hypertension during this type of procedure?
Yes, of course, we do induce hypertension to this kind of procedures when we do them, but we will, weigh the risk and benefits before we actually induce the hypertension for these patients.
Yeah, for your practice, what do you usually use for induced hypertension?
Again, like what Dr. Karen said, we will watch the patient's heart rate and see whether the heart rate is already in the higher side, is the patient tachy, the patient ready, and then we can probably use phenylephrine or use ephedrine to induce the hypertension. But we should keep in mind that all these are short-acting drugs that very limited action.
I see. Yeah, correct. You need to weigh in the risk and benefit and the response as well of the patient, because different patient will have to respond differently from these vasopressors. So we need to titrate them closely. Going back to Dr. Karen, there's one question again for Dr. Hatis. What is your experience for adenosine-induced flow arrest during aneurysm surgery in pediatric patients?
Actually, we rarely do it nowadays, okay, at this age. But this technique can be used as an alternative to temporary clipping in selected patients. So, but adenosine should not be administered in patients with severe reactive airway, severe coronary artery disease, or cardiac conduction abnormalities. And of course, before an anesthesiologist use this, you should be discussing this in advance with your neurosurgeon, because it should work hand in hand with the surgeon as well.
I see. Yeah. Thank you for sharing that. Maybe one of the things that Dr. Derek highlighted earlier on is about ketogenic diet for patients with epilepsy. There's a question in our chat, in our Q&A box regarding, can you just give us, I understand that you have given us already some backgrounds about ketogenic diet. Maybe for anesthesia point of view, what are the primary things that we should know in terms of preparing these patients and during the surgery as well? Dr. Derek?
Yeah, thanks. Yeah, I could have a whole other lecture on the ketogenic diet. So I think the key things you need to know is to treat it like another anti-seizure medicine. Right? It's not a nutritional diet, it's a therapeutic diet. So you must consider it like an anti-seizure medicine. And just like an anti-seizure medicine, you cannot suddenly stop it. So things like giving large doses of sugar, that is like suddenly stopping the ketogenic diet, because you flip them out of ketosis and then back into kind of normal carbohydrate metabolism. So I think that's one thing. The diet is usually administered, or at least at our center, in very specific quantities, like six meals, all exactly the same and spread out. Medications, all the medications are usually tablet, because liquid medicines usually have a very high carbohydrate content. So they have to crush all their tablets. And then, like we said about earlier, before the intravenous fluids, you need to just make sure that there isn't like a large amount of dextrose in it. I think there was a question about lactated ringers. Our anesthetists are wonderful. They will contact us and ask us, this is the amount of sugar, and is this okay? They'll tell us what inside it, and that really is helpful for us to tune it and make sure that we don't have any issues with it. That's most of it. Yeah.
I think from what I gathered is that there should be a close communication between the anesthesia team and the neurology and epileptologist that will actually handling the case. Then at least we can have a discussion of what medications can we use, and mainly also for post-operative pain control.
Yeah, absolutely. Yeah.
Dr. Jaya, there's a question for you here regarding how do you prepare a child for awake craniotomy? I understand you mentioned about having a visit in the operating theater, acclimatizing them with the environment. And what else do you actually do? How do you, describe it to them? Because you mentioned about explaining to them in details after they agreed for awake craniotomy.
Well, the first thing I think when we approach a child with which is planned or child that is thought of, we are going to do awake craniotomy, I think first thing is actually to talk to the child per se first. By talking to the child, I think we can gain a lot of information about the child's maturity. How does the child, you can ask the child what the child thinks about. First thing you can ask the child about the disease or the tumor. What does the child know about what he has, right? Some childs are quite good. And now with media, they use a lot of YouTubes and all. They've actually Googled it before they come to see you, They've already knew what they want to ask you about. So with all that questions, you can actually reduce the child's anxiety about awake craniotomy. So I think the counseling part of it is the main hurdle in success of awake craniotomy. You have to counsel the patient, and while counseling the patient, you yourself will gain knowledge to see whether this child is suitable or not suitable for awake craniotomy. And another thing I think is important is a communication between the multidisciplinary team, right? You have to communicate with the surgeon, with the neurophysiologist, and maybe the neurologist. And then it has to be a collective decision whether we are going to proceed with awake craniotomy for the particular patient. So I think the most important thing, take-home message here is counseling and communication with the patient.
Yeah, thank you very much, Dr. Jaya. I understand that all of our questions actually have been answered in the Q&A box. Thank you very much to our speakers who are diligently answering questions in the Q&A box by text, and all of our questions have been answered. Thank you very much. And with that, actually, we will have a few announcements before we formally close. So I'll be sharing our screen again. And just to remind everyone, the certificate of attendance for this webinar will be sent by email tomorrow. You need to complete the post-webinar survey. Then the certificate of attendance will be automatically sent to your email. Just make sure that you key in your full name, correct spelling, and your email as well. Yes, this recorded session will be uploaded in our YouTube channel, our Facebook page, and our website. Please visit, like, and follow us. So ASPA is a non-profit organization. Our mission is to foster the highest standard of pediatric anesthesia care in Asia. Hence, we seek help to donate and help us in our cause. Please scan the QR code if you wish to donate and help us through this education empowerment. Our next webinar is on December 17th. Our topic is My Focus Moment, Case-Based Learning. We have invited 4 speakers, and of course, with our very own panelists and moderators, Dr. Brushali, Dr. Joe, and Dr. Serpil. So please register. The registration link will be sent together with the post-webinar link tomorrow to your email. So please register and tune in. Our last announcement is our ASPA 2024 in Kuching, Malaysia. To give us a detailed announcement, we invited Dr. Pang from Malaysia. Hi, Yun.
Hi, thank you so much for giving me some time to talk on ASPA 2024. I'll show my screen.
Yeah, we can see your screen. Thank you very much.
All right, dear friends, wishing everyone here on virtual platform a wonderful weekend, rest and recreation, and hope you have enjoyed neuroanesthesia webinar just now. So I am Yun Pang. I'm the pediatric anesthesiologist from Hospital Tunku Aziza, Kuala Lumpur. I'm the ESCO, part of ESCO of Malaysian Society of Pediatric Anesthesiologists and a publicity team of ASPA 2024 conference. I want to express my sincere gratitude to ASPA and Dr. Teddy to allow me to promote ASPA Conference 2024 and would like to have your assistance to spread the good words on ASPA 2024. So ASPA 2024 is going to be held in conjunction with Pediatric Anesthesia meeting of MSPA on 11 to 14 July 2024 in Kuching with a theme of safe, and sustainable anesthesia for every child. So Kuching is situated on stunning island of Borneo, nestled by South China Sea. The capital city of Malaysia is actually Kuala Lumpur, which is in the peninsula. So unfortunately, there will be no direct flight for most of the airline from your country to Kuching. So you may have to stop by to Kuala Lumpur before reaching to Kuching. The conference will be held in Borneo Convention Center, Kuching, and it is located 8 kilometers, 15 minutes drive from the city center of Kuching. So don't worry, on the days of conference, they will have shuttle scheduled on various time in the morning and in the evening to facilitate the travel from Kuching City to BCCK. You can look into ASPA 2024 website for more information and registration. Early bird registration fee is available before 15 March 2024 and standard fee applicable after 16 March 2024. ASPA 2024 committee also welcome abstract submission. Deadline will be on 15 March 2024 as well. And we offer travel grant for those submission from lower middle income countries. So successful application will receive a travel grant of USD 200 for oral presentation and USD 100 for poster presentation. So registration fee will be waived for grant recipients. So all payment will be made in US currency. You have to look up in ASPA 24 website to look into how to submit your abstracts. We have planned a series of captivating talks featuring over 400 renowned international speakers from around the globe for ASPA 2024. The details of program will be available on website next month, hopefully early month. And just to recap that on 11 July, Thursday, there will be a pre-congress workshop, which is Pediatric Perioperative Life Support, PPLS, and Pediatric Airway workshop. There will be a 2 full-day conference held on Friday and Saturday. And the last day, we will end at 12 p.m. noon so that you can plan your visit to this beautiful island of Borneo. We offer a lot of tour sites. You can have going to the beaches, caves, exotic wildlife, including orangutan. You can visit the national park, and there's a vibrant city await for you. So tour package will be available on as soon as possible on ASPA 24 website, and you can actually browse one by one on the website soon. So on behalf of Dr. Ina Ismarati, the chairperson and organizing committee and president of MSPA, Dr. Sipil, president of ASPA, and Dr. Rufina Teo, chairperson of ASPA 2024 scientific committee, we cordially invite you to ASPA 2024 gathering, where we come together to connect and gain the latest insight in pediatric anesthesia from esteemed experts. So we hope to bring together participants from all around the world to make this scientific gathering a truly exceptional. So with this, welcome to Malaysia, and I thank you in advance for spreading good words on ASPA 24. Thank you very much. Back to you, Dr. Teddy.
Thank you very much, Yoon, for giving us all the details for the ASPA 2024 conference. We hope everyone can join us there and meet all of you in Sarawak, Borneo. With that, we are closing our webinar. We hope that you enjoyed and you learned something from our voyage this afternoon. On behalf of Dr. Marichu Batad and the rest of the speakers, I, your captain for this afternoon, saying goodbye and thank you very much for listening.
Thank you.
Thank you.
Thank you.